So welcome everybody. How lovely to see so many faces in the audience. It's great to welcome you all to our clinical networking event, which is all around insight building. And we have 5 presentations this evening. Sorry for the slightly late start, although perhaps that was helpful for people to get here. Might be something to remember. Yes, so welcome. 5 presentations, so we're allowing people 8 minutes for their presentations, and then we've got 2 minutes afterwards for quick questions, but we've also got time at the very end if anybody else has any more burning questions. So do make a note of any questions that you have. We like it to be as interactive as possible. And then, of course, we've got plenty of wine and drinks outside for us all to get together and have a chat and catch up with each other. So we'll look forward to seeing you all. So starting up first, we've got Kubra Aydin, who's a physiotherapist from OMT?
Turkish Ministry of Health.
From where? Sorry? Turkish Ministry of Health.
Osteopathic medicine.
Ah, perfect. So we're delighted to have her here. She's going to talk to us about multimodal... I can't speak. I'm so sorry. Multimodal rehabilitation and insight development after spinal surgery in an adolescent. So welcome, Kubra.
Good morning, everyone. It's a pleasure to be here at Queen Square on this rainy London evening, a perfect setting for reflection and discussion. I would like to thank the UCLH CNR team for inviting me and for giving me the opportunity to share a short case from my clinical practice in Istanbul. My presentation today is titled Multimodal Rehabilitation and Insights Development After Spinal Surgery in an Adolescent. And it highlights how sensory, proprioceptive, and motivational strategies can work together to accelerate both physical recovery and self-awareness in young patients after spinal surgery. To give you a short background, this was a 16-year-old female diagnosed with congenital scoliosis who underwent posterior spinal instrumentation and decompression. After surgery, she presented with complete monoplegia of the right lower limb, no voluntary movements, and total sensory loss below the L2 dermaton. Because there was no neuro-rehabilitation unit in the hospital, I initiated a ward-based multimodal rehabilitation program from the early postoperative stage. The main barriers were reduced insight, low health literacy, and poor adherence. My aim was to design an early-stage physiotherapy plan to combine sensory discrimination and proprioceptive retaining, reflex facilitation, mirror therapy, visual motor feedback, and continuous family guide care. Through this structure and multidisciplinary approach involving orthopedics, neurosurgery, psychology, and dietetics, we aim to promote motor recovery, sensory reintegration, and insight development within just 9 sessions. Now, let's move to the first phase of rehabilitation, the early sensory and reflex activation periods. Early sensory and reflex activation. On the first rehabilitation day, I met the patient and at her bedside for initial evaluation. She had complete absence of voluntary movement and no sensory response in the right lower limb. I recorded that day as her milestone day, the point from which all future progress would be compared. The early session focused entirely on sensory activation and cortical stimulation rather than direct stretching. I use a combination of tactile and temperature discrimination task, cotton, cold cold stimuli, and pinprick to reactive afferent pathways. With her eyes closed, she learned to identify which toe or finger was being touched. Through proprioceptive retraining, I encouraged to her imagine and send signals to her weak limb, starting first with the unaffected side, then transferring the same pattern to affected side. We also introduced mirror therapy, allowing her to observe the movement of the healthy leg while visualizing similar motion in the paretic side. And home-based tactile stimulation, I provide education on hydration, potassium-rich nutrition, B12 supplementation. On the second day, we use Babinski stimulation with cold tapping. Following a minimal plantar and dorsiflexion attempts under guidance. These early signs suggest cortical reconnection, which became the funding for the next phase. This is, by the end of the first week, we began to observe remarkable progress much faster than what is typically reported in the literature for post-supinal surgery rehabilitation. The patient was initiate, isolate, dorsiflexion first briefly and then maintaining it for nearly 5 seconds without plantar drifts. This demonstrates a clear improvement in the both motor control and proprioceptive awareness. By the 1st of September, she could perform a straight leg raise against gravity and maintain knee extension with stimulation dorsiflexion, showing coordinated activation of the quadriceps and tibialis anterior. She also achieved independent rolling and sitting on the bed without assistance, which indicates recovery of trunk control and intermuscular coordination. During this stage, I deliberately avoid early ambulation to prevent false confidence and ensure neuromuscular stability. Meanwhile, despite my caution, the family began pressuring for early discharge, interpreting visible movements as full recovery. This period reflects not only motor learning but also the challenge of maintaining realistic expectation in a family with limited health literature. Her progress during these 5 to 6 days was remarkably faster than typical literature expectation. Usually 3 to 4 weeks are needed for similar recovery levels in monoplegia. It means rapid control adaptation, showing how early multimodal physiotherapy can accelerate both motor and cognitive recovery when guided properly. Her gait symmetry, trunk control, and directional turning improve day by day. Standing balance while drinking water and perform rotational turns without assistance. Functionally, this phase represents the integration of sensory, motor, and cognitive recovery. She could think, plan, and execute movements in real-life context. However, this improvement also triggered a psychological shift. Both she and her family began insisting on early discharge, believing recovery was complete. This situation reflected an essential part of rehabilitation, developing insight and awareness of ongoing needs, not just physical ability. In summary, her recovery trajectory was consistent with the evidence that early cortical reorganization in adolescence supports faster and more complete functional outcomes, even in non-specialized ward settings. This case reminded me that recovery isn't only about movement, it's about awareness and adaptation. Every step she took reflected not just neuromuscular progress, but also emotionally and cognitive growth. Thank you for listening.
Thank you so much, Kubra. That's amazing. She recovered really quickly. Have we got any questions from the audience? No?
I've got one. So, obviously when you're training patients within sensory components, did you do it, I might have missed it, but did you do lots of training and coaching to carers or family members? So
Yeah,
on?
of course. As I told you before, it was the most important for us to give them how they move, how they take their patients to go to toilets, how they could give her meals, and that's the point actually. And it's an important thing to collaborate with their families because we are together.
Yeah, absolutely.
Yeah.
Great talk, thank you.
Oh, brilliant.
Thank you.
Thank you very much, Kubra. Thank you. So next up we have the team from Tower Hamlets community. And this is Kayla and Ayanna, and they are coming to talk to us. Oh, let me get your thing up. And they're going to talk to us about optimising insight after TBI. Thank you both so much.
So my name's Ayanna and I'm a speech therapist.
And I'm Kayla and I'm an occupational therapist. And like they said, we're from the Tower Hamlets Community Neuro team, and we'll talk to you about a case study about optimizing insight and participation after TBI.
So in January, Jose, which isn't his real name, fell while intoxicated. He was brought to the Royal London Hospital and found to have bilateral subdural hematomas and subarachnoid hemorrhages in the frontal lobe. He was a trilingual retired chef who had been volunteering at a food bank, and he had a history of alcoholism and was estranged from his family with rent arrears, which made his discharge complex. He was declined from level 1 rehab due to his alcohol history, and during admission he became homeless. Because of his cognitive and communication changes, he was assessed as requiring 24-hour care needs and was discharged to a care home.
So when our team picked him up in June 2025, physiotherapy discharged him at baseline. When I assessed him, I noticed he was independent in his ADLs, but under a community DALS, and required one-to-one support for higher level tasks such as cooking or going out into the community. He had poor attention, impulsivity, and significant cognitive communication deficits, which made him very vulnerable when out in the community. For example, he was impulsive when crossing the roads, and he escalated in social interactions. He was fixated on bus routes and would not take or follow any social cues to shift to any other task or topic. He was unable to engage in any formal assessment or conversation about his brain injury. His cognitive communication difficulties were making my OT assessment and input challenging, so we started working together.
And then I found similar results, but alongside his severe cognitive communication difficulties, he also had frustrations with word finding difficulties and reduced comprehension of verbal and written information. However, when playing simple game of cards, we noted that he could engage in a functional task much better, that more effectively than a conversation. And during these activities, his verbal output reduced, and he was able to attend and learn the rules and take turns. So we thought that showed that he couldn't talk about his difficulties or teach strategies. They had to be kind of in function in an activity. And it was difficult to engage him in rehabilitation and safety planning because he lacked insight, which was influenced both by his cognitive difficulties, particularly with abstract thinking, and by limited environment of the care home. So we were running into a few barriers in his rehab.
However, we also identified some good facilitators we could use to build his insight and work towards his goals. So he was very motivated and engaged with his goals, such as shopping, going to the farm, or volunteering. His attention and comprehension, like we said, were better during functional tasks, and in these tasks, when he made a mistake, he took on the direct feedback. His episodic memory was also a strength, so we were able to use that to build carryover and learning and insight into his meaningful activities. And he also had a really supportive care home team and family who participated in all of our brain injury education and could supplement therapy and provide that consistent feedback.
So then we also came across Sheila McDonald's Life Integration Approach, which was a clinical focus article which provided a framework to implement cognitive communication interventions through functional participation, contextual learning, collaboration, and identity reconstruction. So that fit really nicely with his rehab.
So there are 10 components to the life integration approach, and we have listed some of the relevant ones here and how they looked like in his care. So we began with functional goal setting with Jose. His goals were centered around returning to independent living, exercising, volunteering, shopping, and going out on his own. Notably, his goals weren't about any of his thinking and communication skills. His family also shared concerns, though, about their relationship strain, so supporting more enjoyable and successful conversations was also a key functional goal for us.
And then Jose had been unable to access meaningful activities for over 6 months, which deeply affected his identity and well-being. So to address this, we provided intensive input, and we decided to see him separately and also refer to rehab support worker for additional weekly sessions, and alongside those, his family contacts supplemented. And then the sessions all took place outside of the care home, so in like the farm or the cafe, to ensure that he was immediately going out regularly.
So we completed these assessments in context and simultaneously began the functional task practice. So this included road safety assessments and observing and supporting him while ordering coffee, shopping, or making phone calls. We provided in-the-moment feedback to build insight into any challenges he was facing during those tasks. And over time, we worked on grading down the level of support so we could promote his independence. To make therapy part of his everyday life and outside of just therapy sessions, feedback was also consistently gained and provided to his network around him. So we also provided the MDT, the care home, and his family with education on that in-the-moment feedback we were doing with him so that everyone was using consistent language and reinforced the same strategies.
And then we focused on areas that caused risk or were barriers to independent community access, because that was what was most important to him. So crossing the road safely, managing or diffusing situations in the community, problem solving in unfamiliar settings, and preventing relationship breakdown. And then we identified practical strategies to support these areas and then consistently promoted Jose to use them, helping him build insight through action and repetition. And the goal of his insight building was for him to apply the strategies to day-to-day activities to allow him to do his meaningful goals.
So one example to manage his topic fixation was that we agreed a gesture with Jose to indicate stop and reset during conversations. We also worked on highlighting designated crossings before he had a chance to impulsively cross the road. So he was prompted to plan out the route and cross safely. With repetition in familiar environments, he began to recall and use his strategies across these different contexts and things he wanted to do during his day. We also worked on advocating for Jose to engage in his DALS assessment, his lasting power of attorney decisions, and rehousing. This involved using functional reports of our assessments and our sessions and what supported him, and conducting joint sessions with a clinical psychologist and a social worker where we were able to assist.
So the outcome since starting rehab, his DOLS restriction has been removed. He has demonstrated capacity for lasting power of attorney decisions. He's accessing the community independently, so he's shopping, going to the library, going to walking groups, doing his shopping, going to the outdoor gym and volunteering. He no longer requires 24-hour care, and his family relationships have improved, and his son said there's more natural back and forth in conversations and less verbal diarrhea, which is nice.
So Jose doesn't explicitly say that he has a brain injury still, or list any of those cognitive or communication difficulties. When we asked him to explain his brain injury, he gave the shortest answer we had ever heard from him and said no. But we are seeing consistent, clear evidence and insight in his daily activities. So he tells staff where he's going, he looks both ways before he crosses the road and asks for clarification and is honest when he doesn't understand us. So while he may appear to lack insight in the traditional sense, he consistently demonstrates an understanding of risks and applies strategies during his meaningful activities.
And then, importantly, like overall, his engagement in meaningful activities has boosted his well-being, which you can see in the quote, about my problem, I appreciate you for my situation. It's up, much better, it's simple. No, it does go on, but...
So our main takeaways were that insight building wasn't done as a separate task. It was naturally embedded into his daily routines and meaningful activities. He also had so many professionals involved in his care, and a priority of our care was that everyone in his network got consistent education. This ensured that all members were providing the same messages, feedback, and rehabilitation helped his day-to-day to generalize his learnings across contexts. As a team, we also recognize that he really benefits from an MDT approach with intensive and flexible input, so we were able to adapt our prioritization system to make this happen for him.
And then Jose's insight doesn't look conventional. He might not explicitly say he has a brain injury or list his difficulties, but you can see his insight through his actions, and he compensates for his difficulties often. And then overall, just don't count out the 70-year-old with a long history of alcohol use and limited insight, because he did make a lot of progress and he's now accessing the community on his own.
Yeah, so thanks for listening. That's all.
That was really very good. Thank you, girls. That was amazing. Any questions from the audience?
Lots. I'm going to bring a mic.
Kate's going to bring a mic up to you all.
Thanks. That's a really great piece of work. Do you know, obviously he had this TBI, but and this long history of heavy drinking. Do you know if he had pre-existing alcohol-related brain damage on his scans?
Yeah.
Because I'm actually a consultant on one of the level 1 units that would have declined this guy.
Yeah.
So it's just interesting to see that, you know, people can make progress despite that. But so he did have clear cut, because that's why he would have been declined, I suspect.
Yeah.
Yeah, it's very interesting. Thank you.
Yeah.
There was another
Davina,
one at the back.
at the
Davina.
Thank you. I just wondered over what time frame and that level of intensity. I think you said weekly and you got the family involved, but how long from when you met to this
We
point?
met him in June, and we're still seeing him.
Right.
It was June, wasn't it?
Yeah. There was like a period there where he was getting 3 sessions a week, because one from Ayanna, one from myself, and one from a rehab support worker. And we carried that on for probably a couple of months. So he did get like a pretty good chunk, but it only took 1 session from us each week.
And then now I'm seeing him still weekly, and you're seeing him.
Like every other week.
Yeah.
Because I just wanted to raise the question to the room of the timing of your input, because often these people are extremely agitated sort of for a long period of time, and giving them a safe, sound environment for a prolonged period of time. I always ask myself, when's the best time to give the input? So
I think when we met him, he was very distressed, and he just really wanted to go outside, which is why we took all of our sessions outside. And he'd been kind of advocating to get himself outside, but it wasn't appropriate, and the care home didn't know how to like transition that. So that was our first goal.
Yeah, but then I guess going outside with us, he built trust with us that we were working on his goals, and we could kind of help support that safety outside, which was quite helpful. Yeah.
Any more questions? I've got a quick one. So, as a physio that gets people walking often quite quickly, and then you think, oh lordy, because they're falling all over the place because of their lack of insight. Were there safety nets that you had that you knew he wouldn't take himself up? You know, I went yesterday, so off I'm going today to the coffee shop or the farm or
The care home was very, very supportive, and I think we were really lucky that they were on board. So the place he was at, there was someone at the front desk, and I think because he trusted us so well, and the concrete thinking kind of worked in our advantage too, he did actually follow our rules.
Yeah.
So that was quite helpful.
And convincing him to, like when we graded it where he could go on his own, he was like, no, I can't leave without somebody, and we had to really persuade him.
Yeah,
and then we had a tracking app as well, so that if he did.
Yeah, so the tracking app, he was prompted, once he started going out on his own, he was prompted by the care home staff, do you have your phone, do you have your brain injury card, and where are you going? Which just kind of gave him some prompts to think about where he was going, make a plan known, and signpost him to the resources we had for him. Yeah.
Brilliant. Thank you, girls. That's great. Okay. Next up, we have Dr. Leigh Leppard, who is the Principal Clinical Psychologist at Bethlem Royal Hospital. Lovely. And he's here to speak again about insight and executive brain functions in acquired brain injury. Welcome.
Thank you. Hi, everyone. 8 minutes is really not a long time to get through a lot of this stuff, but I'm going to try and go as quickly as I can. I wanted to present a small-scale pilot study that we're doing at the Lichman unit. It's something that, as you can see, there's lots of logos at the bottom there. It's something that's being done jointly with Brighton and Sussex Medical School. Professor Natasha Segala there is the lead researcher, as well as us here at the Maudsley. And it's being funded by a grant from the Academy of Medical Sciences. So I don't know if any of you know much about the Lichman unit, but there's a picture of our dining area. We're a level 1 neuro-rehab unit. We're based right on the edge of sort of southeast London, on the very edge of Bromley borough. And we specialise in neuro-rehab and neuropsychiatry, and we specialise in working with people who have comorbid or premorbid mental health needs, or maybe have neurobehavioural disability. We don't see people who have severe challenging behaviours necessarily, but it's more kind of dysexecutive or cognitive communication problems and things like that. We generally see people for 3 to 6 months, although as with a lot of inpatient units, we have lengthy delayed discharges because we have very complex people that we can't get out of our doors into the community. And I guess our typical patient would be one of those conventional kind of walking wounded type people with executive functioning impairments, among other things, and usually poor insight. And as Dr. Medford said up there, who I forgot to mention, he's also one of the researchers. Sorry, Nick. As he mentioned, the kind of person that we might see might be the kind of person that was described in the previous presentation. But it sort of got us thinking about what's going on with insight and executive functioning, and that's what's led us to this research project. So what we know is that it's pretty common to lose insight in the early stages of a brain injury recovery. And it's associated with poorer rehab outcomes, because if you're not aware of the problems that you're facing, then you might be less motivated to improve. You might struggle to recognise when you need to use compensatory strategies, and you might not be able to correct your performance based on feedback that you're getting. The problem is that the nature of the relationship between insight and brain injury recovery isn't that well understood. And there aren't that many kind of established rehab interventions specifically for insight. So we wanted to kind of do something a little bit exploratory and try and figure out what some of the mechanisms might be. So our key research questions were, does inpatient rehab make a difference to insight and executive functioning? And is there a difference really between people who have poor insight and people who have good insight in terms of their executive functioning profile? So we are running, as I say, this pilot study. We're aiming to recruit 20 participants, so at the moment fairly small and a bit exploratory. And put simply, we're doing pre and post measures for all of our participants. So on the insight side of things, we've got the self-awareness of deficits interview, and we've got the schedule for the assessment of insight, which the latter there, that comes from the world of psychosis and sort of it's a bit more mental healthy, but we've modified it to make it more appropriate for brain injury. And then on the executive functioning side, we're using the DKEFs, which people may or may not have heard of, but it's a very robust and well-established executive functioning battery. And these are the kind of things that we would use anyway with our patients, but we thought that we would specifically administer these to gather a bit more information about how someone's executive functioning might be. So it's fairly early days and we've only got preliminary findings, so I will talk you through them, but obviously we can't draw too many conclusions from them so far. So we've recruited 5 participants out of 20. The reason for that is that we're having a little bit of trouble. We've got some prolonged building works that have shut half of our beds for a while, but I found out today that we're opening up fully now, so hopefully we'll be able to admit more people and get more participants in. And of the 5 people we've recruited, 3 of them we've got both pre and post measures. Just by chance, the first 2 participants we recruited are kind of a little bit anomalous. They're not the kind of people we would usually see because they were people who were coming from home rather than from an acute ward, which is where we usually get our referrals from. And they were quite some time post-injury. And they were both coming in because they were really struggling with poor initiation, and we were going to trial them on a stimulant. But we thought we'd run them through the battery in a way and see how they did. And as you can see, there were some signs of improvements. We've not done any stats on any of this yet. It's just really eyeballing it for now. And the third participant that we've put through our study was a much more conventional kind of neuro-rehab patient, someone who came from an acute hospital. She was a 30-year-old woman. She was about 4 months after her injury. She had a stroke and went into status epilepticus, and she showed consistent improvements on both the measures of insight and the measures of executive functioning. And I guess, like I said, it's a bit early to draw conclusions yet. We are going to recruit more people and try and figure some of these things out a little bit more. But what we're hoping for is that the findings that we're going to draw from this study might just help to kind of point us in the direction of sort of new research avenues and things like that. Might raise a few more questions that we can explore, because really ultimately what we're looking for is something that can to identify new treatment approaches and find ways to kind of improve insight in our patient population. But the reason I thought I would bring it here is because we're early days and we're doing this pilot study, and I really welcome any feedback or thoughts that anyone might have. So I'm going to pass it over to you.
So over to you all. Any questions? Any comments? Any? Okay, we've got one up now.
I'm just curious about, and as you say, it might be early days for this, but thinking about the functional implication on that on discharge. So obviously people with executive function and insight issues, you try and get them back into the community, and that's typically where things go a bit pear-shaped. Just curious about follow-up once they are discharged and in the community. Is there any measures around that you guys are thinking of doing, or?
No, that's a good point, actually. We're not. And it's largely because once they leave the Lischman unit, we don't really have anything,
the
they're not
practicality
open to
of
our
it,
caseload, so it'd be difficult for us to follow up. But actually, that is a good point. What were you thinking then about just kind of seeing if it was sustained or seeing what the functional outcomes
Exactly,
might be?
and seeing kind of what the, if there are any issues with insight that impact on day-to-day function, kind of thinking about your guys that have come back in that have become passive or whatever may have you. We know that level 1 units are highly supportive and structured, and often these patients then maybe go into a care home where that level of support isn't available, or they go home where they're open to so many more risks and access to different things that are more challenging. So just wondering about like links with local community teams or that kind of follow-up work of what it looks like in function once they're out in the community.
Actually, that sounds like a really good idea. That could be some. I mean, it's not something we can do for this particular study, but something as a further option for research. Actually, one of the things that we do on the Lischman unit is that we're quite keen on getting people home for kind of trial leaves and weekend leaves, and we often go out with our, the therapists might go out and observe people in day-to-day functioning. But you're right that longer term thing, it's okay to see someone for a weekend or overnight, but how they're doing a month later or 6 months later when
the structure is less.
Yeah, absolutely. It's a good point. Yeah.
Thank you.
Thank you.
There's one down the front here, Kate.
Hello there.
Yeah, I'm coming.
She's coming. Come on, girl.
So obviously you're looking to find sort of new treatments. What sort of approach are you using at the minute? Like the more traditional approaches, and what have you found that's worked? I mean, I work.
Yeah, so I suppose, a lot of this might overlap with the previous presentation actually, because I suppose kind of trying things out and seeing what's working, helping people to reflect back on successes and failures and things like that. Are you familiar with the kind of Y-shaped model of rehab? That sort of thing is the kind of things we might do. But I suppose that's partly the question as well, is we are doing these things, but what's working and not working. At the moment, for all of our patients that are going through the study, they're kind of having treatment as usual. So that would be OT, physio, SLT, psychology, psychiatry input, and social workers as well. So there's a lot going in. And I suppose this is just putting out feelers for what's working, but in the longer term, it'd be really interesting to try and actually tease out specifically what are the key ingredients, what are the mechanisms that are helping. But don't know yet. We're working on it.
And then, sorry, just one question about the home leave. So the level 1 unit I work at, we also do like day leave, weekend leave prior to discharge and things, and also to help raise insight. What I've sort of found in the cohort that we have at the minute is that everyone sort of comes back and it's like super positive and everything's great, and family are also really positive as well because they're in home for the first time in months sometimes.
Yeah.
So is there anything else that we can maybe trial when they are at home to see actually what is, is it super positive, or is there just there's everyone just really happy that someone's home and they're maybe overlooking some changes? Because we tend to find that when they're discharged, we then get emails and calls, this is different and that is different, and
right.
I'm just wondering something that we can do to sort of safety net them in advance.
Sorry, where are you working? Where are you based?
Wolfson.
Okay.
St George's, yeah.
Yeah. So it would depend on kind of what your resources are, because we tend to do kind of maybe weekend leaves or trial leaves over a prolonged period. So there might be that honeymoon period initially, but if you do it for sort of 6-8 weeks of them going home every weekend, then suddenly family members start to realise that things aren't as they seem. Or we might have our clinicians go out there and do a cooking assessment, or let's go around your local community and see what's what, and then we can observe directly what's working or not working, or what they're struggling with as well. Okay.
Does that change as discharge becomes more imminent?
Does what change, sorry?
How difficult things are at home at the weekend.
It can do, yes, yeah. And we do sometimes have those people who, everything's going fine and then suddenly it's not, and they must stay another month, you must please take them. Yeah, that's true.
There's another one at the back, Kate. Come on, get your running legs on.
Start with.
Thank you. Just following on from that previous comment and question, and I appreciate this is probably outside of the remit of this part of the study, but I wonder if you thought about engaging the neuronavigators across London in how you think about that discharge planning, because I think with the best will in the world, your transition planning of really quite complex plans and strategies are going to be planned from within that ideal environment, and the environment that they're landing in is going to be so different wherever that patient lands, that actually thinking about how you tap into those kind of local connections to the local teams, because you're not going to know every single team you're discharging to either. That's an impossibility. But whether that link in terms of planning how things go might be something to think about.
Yeah, absolutely. We do try and work with neuronavigators every time. Are you a neuronavigator by chance?
I'm not, no. I'm clinical lead for a community neuro-rehab team.
Right, okay.
We're up in North West London, but we often get clients, we do get some that are relocated from South London, from all over, depending on where they end up in rehab units.
Yeah.
So it's, I think that we're on the receiving end of what often looks like an incredibly well-planned piece of work, but we often catch up with what's been planned after the event, and often after the wheels have fallen off, which obviously we don't want to happen.
Absolutely. So we wherever we know that there's a neuronavigator involved, then we try and involve that neuronav as much as possible. You're quite right that sometimes we don't make the referrals to CNRTs until the point of discharge, although we might liaise with them during that transition period. But yeah, you're right, there's always scope to do more of that, of course. But I do think it's a good point that those kind of, if those links could be better forged, then that would definitely help our patients kind of smooth that pathway. The other problem we have is that we're a national unit, so it's really nice when we have someone coming from London who has a neuro-navigator who's heavily involved, but sometimes if someone's coming from Southampton or Essex or Kent, then they might not have anyone involved when they leave our unit. So we should have neuronavigators nationally, I think.
Absolutely. Thank you.
Okay.
Brilliant. Thanks so much.
Thank you.
Okay. We have Simon and Faye from here talking about an SLT team's toolkit for supporting increased self-awareness of CCD. So over to you, Ben.
In case you don't know which one's which, I'm Simon. Okay. My colleague Fran. So we're going to be talking through our toolkit for supporting increased self-awareness of cognitive communication disorders. But that's with a slight caveat. It's not, we don't go in cold. This is after a period of trust and rapport building, always in collaboration with MDT and never in isolation. It's embedded within other approaches. But the list, just go through it all, that we try with different people in different combinations is obviously education about brain injury, cognitive communication disorders, what it might look like, gathering feedback from credible sources, using things like the Latrobe Communication Questionnaire that's already been mentioned. So this is a survey that you do with someone else and the person with the brain injury to compare responses around kind of communication behaviours. We might do assessment and feedback, and that might be formal assessment or within, in context assessment. We actually do lots of video in SLT, so we do lots of video recordings and then watching back and reviewing. We run groups, and the main tool that we harness there is peer feedback. Again, another credible source potentially, rather than the therapist telling them. We also use meditative cognitive strategy instructions. So thanks so much, Laura to Kim, for explaining what that is, because now I don't have to. A framework we tend to use is the goal, plan, do, review. And then we also use identity mapping, which maybe some of you aren't aware of, but it's linked to that identity reconstruction concept that was introduced by the Tower Hamlets team. And it's not for insight raising solely, but it can help people explore different aspects of their identity by self-generating identity descriptors. So we might explore the person they were, the person they want to become, or the person they are at that moment. And we're going to illustrate some of the use of those tools through 3 very small case studies.
Yeah. Thank you, Simon. So the first case study we're going to run through, and the idea of that toolkit is that not all of it works, right? And you might use some of it, you might pick trial and error, and this is, the 3 examples kind of cover, I guess, a bit of a mix of what we used and what worked. So our first chap we're going to go through is a man who was on our rehab unit recently. He had a right-sided stroke. He's in his 50s, and prior to his stroke, he was working as a hairdresser. He had significant cognitive communication disorder. Quickly run through some of the features, but he had a lot of kind of separation, rigidity of his thinking, reduced recall. He was quite repetitive in his content, in conversation. He was highly distractible. He was tangential, constantly changing the topic, and he had reduced spoken and written comprehension as well. And he had no insight when we asked that classic question that you talked about. He couldn't verbalise that at all. He had no awareness that there was any change to his communication at all. But he did have a lot better insight into his physical impairments as a result of the stroke, and he became quite fixed on these. So he was aware he had weakness, he was aware he had quite a lot of pain, and that tended to really dominate our conversations. So because he had no insight into his communication, obviously we initially wanted to focus on raising that insight. So our intervention, as Simon, thinking back to that toolkit, we first kind of fed back his assessment results, so the clear impairments in his assessment, but he really just attributed that to, I didn't do very well at school, I wasn't very academic. We did the Latrobe questionnaire, so that feedback from credible sources, important people in that person's life, that was his partner. But unfortunately he was very defensive about that, very dismissive about the partner's observations of his communication, and even to the point where he was like, well, she shouldn't have married me then. So I was like, okay, so what should we... So that we hadn't had much luck kind of at that point. So we tried the education approach and made a kind of bespoke communication book for this gentleman where we kind of went through changes after his brain injury, including his communication and the steps that we were taking kind of in rehab towards working on that. And then we kind of used it across the MDT, consistently being used to providing that frequent contextual education using his book. And he also was offered to come to an education group, but he mostly declined that. He kind of prioritised family visiting, other things. He just wasn't really prioritising it. So we went on to what did work in the end, was the identity mapping approach, and he was very responsive to this. So whilst he did continue to classically kind of deny any cognitive communication changes, the identity mapping enabled him to kind of acknowledge that actually he wasn't communicating in the way he wanted to and the way he would have done before. He was a friendly, chatty man. He would kind of draw things out of others in conversation, like a lot of hairdressers we probably know do. And he just was able to recognise he wasn't currently acting in that way. So he set a subsequent goal based on re-establishing that part of his identity to find out about other people, essentially by asking questions. So, and he facilitated it, that kind of facilitated his ability to participate in strategy training and working towards that in the group therapy, which included video and peer feedback, like we talked about as well. So it was really successful, and there's just an example of the identity map there. This is a woman, unfortunately, he's a hairdresser, but you can imagine him. Yeah, thank you.
On to our second case study. So this is a man with a right cerebral hemorrhage, also with cognitive communication disorder, that was characterised by reduced attention, reduced eye contact, poor turn-taking and topic maintenance. And he really dominated conversations and talked over and interrupted others. And of course had poor insight into this and was reliant on his conversation partners to repair any breakdowns. So we use different aspects of our toolkit, and he did actually engage really well in all of them. But in most of them demonstrated that kind of intellectual, theoretical awareness. So when we went through the education, he's like, yeah, I accept what you're saying. He and his mum did the Latrobe communication questionnaire. They had really good agreement on kind of the features that had changed in his communication. But it wasn't until we do video feedback that he really got what we were talking about. He could see immediately what was wrong. He's like, oh, I'm doing all the talking, and me in this case, you're not doing any of the talking at all. So that was really powerful in terms of readying him for change. And so, and it really bothered him because he was a highly sociable person with a strong network of friends. So subsequently, he identified a goal to know when to talk and when to listen, and to allow better conversations with family and friends. On to you, Faye.
So our third case study is, I didn't actually...
Oh, do you want me to do it?
I thought we were doing this one together, but...
We can do this. We work with this man.
Notes, yeah.
This is the third case study. And I think he's another right-sided cerebral hemorrhage. But he was really interesting. So when we went to see him, he was really worried that something was going to be wrong with him, his communication. He felt there was no issues, but he was really wrong that we would find something. So we didn't go down that assessment and feedback line at all. We didn't feel he was ready for that at the time. His wife also felt there were no changes either, but it was really interesting when we did the Latrobe communication questionnaire with them, they both started to think, oh, actually that has changed.
Yeah.
That is different. That is happening more. So we started to get little glimmers of the insight, but what was most powerful for him was the group and the peer feedback, and I'll let you describe that.
Yeah, so having had that quite difficult start actually, and we thought, okay, and this comes back to the toolkit, what where we can be flexible and might need to try a different approach, was actually that feedback from his assessments that was very clear to us. As soon as he got into the group scenario, and as soon as he could watch himself and he had that feedback from peers, he was suddenly like, gosh, this isn't me at all. He was very completely on board with us straight away about what his goals were. He would then remember them each week, coming back, remembered this instance where he'd interrupted, for example, another of his peers, so that was one of his things, so he was quite verbose in conversation, and he'd really taken that to heart because of the impact on his peers. So it was very powerful, and that's really been our way in, and it's continued to then generalise into kind of meetings and other settings where he was also very verbose. So yeah, it's a nice kind of example of where, again, just that permission to kind of step back and think about, we still wanted to offer him that variety of approaches just to kind of see what works from the toolkit, really.
So some quick conclusions for you. A variety of tools can help build insight and awareness, but it won't be the same tools for everyone. You need to be, well, hopefully we are, responsive and flexible to the individuals and be prepared to try different things. And as actually other people have said, I don't know that we often get full awareness, that listing of their impairments, if that is even what awareness is. But what we aim for is to get acceptance that maybe something's changed and that speech therapy and MDT input can help.
Thank you.
Any questions for Simon and Faye? Over there, Kate.
Sorry, be a bit. I'm probably loud enough. Yeah. With regards to the identity training, which is great, I guess in neuro-rehab, people stay with you for some time. At what stage do you start talking about identity mapping, and do you use a template or some kind of framework? Is it more MDT-led or SLT-led? Yeah.
Yeah, so it comes from the work of Ilvasacker and Feeney. So they, in their papers, have a template that we often use. We actually modified it for this gentleman because he was really concrete. So we just really focused in some things that we thought he'd be prepared to talk about. But Ilvasacker and Feeney have a much nicer template you can use. We actually don't do it with everyone. No. We kind of are responsive to that individual needs, what they're talking about, what we think will be useful to them. And we do it, we often lead on that approach, but within the MDT. Yep. So we often do that work jointly with psychology and others, and obviously what comes out of it has to be shared.
And we have that kind of the templates of thinking about the now and then the future them. So the kind of where we're at, where they're sitting in now on a variety of, like you can see in these areas, but thinking that model of where they would like to be. And yeah, it can be very successfully done with psychology and then building. Often we work with the MDT to remind that person of you might be being more, I don't know, whatever. For example, this chap, if he's in a physio session, could he ask me a few questions about my weekend or whatever it might be. So trying to build that into his week, not just in our sessions. So yeah, and I think you said about when do we do it, and I think often it's that rapport building that's important at the beginning. So we might start with that assessment, but really gauge where they're at in how accepting they might be of that, and then go from there.
Yeah, because we've had people that it's been the first thing we've done, and there's been people it's been the last thing we've done. Yeah. And I use it with outpatients as well as inpatients.
I guess it depends on the individual.
Yeah.
But in a way, you give them the control and say.
Yeah, that's what's really nice about the approach, because there's no wrong answer, because it's about their identity. Yeah.
Thanks. Another excellent talk. Are there people you wouldn't use it with? Because I can think about certain patients that have been through our service where maybe this would be quite confronting, actually, and maybe sort of ramming home the before and after, and the differences is not something you want to do. I mean, I completely agree with what you say about you can't have a one-size-fits-all approach. It has to be individually tailored. But are there patients where you would think, actually, maybe we shouldn't be doing this with this particular person?
Yeah. I think with all the approaches we listed, I could think of a scenario where I wouldn't do that, any of those, with some of our patients. So it is kind of getting to know people, being responsive to what they're saying, thinking what will work, being prepared to stop something, when it becomes very clear it's not working.
And explaining it before. We're not just going to plough right on in, we're going to explain what that might look like. I wasn't accusing you. But for some people, they will say, actually, I'm not ready for that whatsoever. And of course, you respect that. And
Another one in the middle there.
I was just interested on that last gentleman. What was the turning point? Because it sounded like he was not really responsive to that feedback.
Yeah, and I think it was something about the setting of the professional and the patient giving this quite, what we get from quite formal assessment feedback to actually someone he was just such a sociable guy that he couldn't imagine that around the pub around the table in the pub that he might have, I don't know, offended somebody, and that was the dynamic in the group where he could understand that, I think, and relate it a lot more to him. Whereas I think he kind of felt a bit like he was at school, or we were sort of telling him, you got this mark wrong, and that just was. Well, I hope we weren't doing it like that, but I think that approach just did not sit with him, and it's just about trying those different contexts and perhaps slightly less. If you can't identify those things in yourself. How do you link that? Whereas if somebody else gives you that feedback who isn't one of us, or he just kind of seemed to latch onto that in a more functional environment, like a lot of our patients. It sounds like.
Thank you.
I've got a quick question. So, if people have really poor insight into their own cognitive communication disorder, are they able to recognise it in others?
Ooh.
So with the group, do you see what I mean?
Often yes, often they will give that feedback of, especially when if you might give a prompt of, well, how was the balance in that conversation, and actually even though that person might be less aware of their own input in the conversation, they might be very aware that somebody else was talking all the time and they didn't get a chance to perhaps get their turn in potentially, or that kind of thing.
Although I can think of one group I ran with two rather tricky individuals where they ganged up and kind of made a case of why I was wrong, they were right, and actually how my communication was not what they would expect. So,
There you go. The joys of conversation groups.
But they made a very good case and I was persuaded.
I got feedback. Any other questions?
I got feedback,
You've been a fabulous audience. It's been so lovely to see so many of you here tonight. We hope you don't all have to rush off. We hope you'll come out and join us for a glass of wine or two and perhaps some crisps if we're lucky, and we can carry on the conversations. But mainly I'd like to thank all our speakers for really brilliant and insightful talks. So it was really great. Thank you.